Thank you, Debbie, and I apologize for the microphone issues. I guess we're about to. Now we have a new one. I think it's fair to say that Debbie's presentation was indeed the right thing at the right place at the right time, and we thank you for that. We're going to move on to the next presentation, which is a first panel, and I'm going to call on Celso Ramos, our good friend from Rio de Janeiro, Brazil, to moderate the panel. In addition to his academic appointment in the Federal University of Rio de Janeiro as Associate Professor of Medicine, Celso is actually chair of the board of IAPAC. Celso, all yours.
Thank you, Julio. Yes, I'll invite Dr. David Zavada, who will be speaking, and I'll also invite the other members of the panel, Dr. Wafa Asala, Baden Nozick, Fabio Mesquita, and Alan Whiteside. We are a bit late, so I would appreciate if you could keep your talk to some 15 minutes or so.
I have 100 slides. First of all, I would like to thank Jose, Julio, and Ken for inviting me to come and speak on this forum. This is my first time to attend this meeting, and I appreciate the honor. In trying to prepare for this presentation, I really found myself going down memory lane. And when I got here, I just figured out, gee, all these groups, people I see here are all in HIV. I don't know what new I'll tell them. But I figure there are some young people who probably could hear a little bit about where we came from, where we are, and where we're going. So my talk is going to be about aspiration, the tools to achieve our aspiration, and the reality. But first of all, I'd like to tell you, and I'm going to tell this story through my eyes as growing up working in HIV. There was time ago when, and my prism is going to be through Africa, when HIV hospitals, mainly in Africa, were just full of sick people. Actually, you had malaria or diarrhea, you had a tough luck to get in. There were lots of people all over the floor. Treatment was symptomatic, whatever little we could. And most likely, we had a prayer for you, literally. I'm talking about the national referral of the hospital in Mulago in Uganda. A Bible. We had some doctors giving out Bible. Stigmatization was a big issue. We have talked a lot about stigmatization. We had prevention was basically faithfully one sexual partner, abstinence, symptomatic treatment, or testing and counseling. That's all we had. However, we had aspirations. And looking through this, I couldn't really, I was reading through where we have been. And what is so striking is that the AIDS activists, which we don't see much these days, but they really gave us the aspirations which we still hold dear to now. Ending stigmatization and discrimination was a huge issue, and still is, as we see throughout my thread of presentation. But access to treatment, and that we have had a good success over the years. But stigmatization and discrimination has always been our aspiration right from the start of this HIV epidemics by these activist groups. However, we have had aspirations also. WHO has had UN has had a number of declarations over the years, starting from 2001 all the way to 2011, trying to give us our goals and aspiration and the political leadership. UNAIDS was formed to deal specifically with this problem. Global Fund was also formed to give a mechanism of funding to be able to deal with this problem. So there was a response. And UNAIDS goals, the points, now the current UN goals are still, and they are 10, but I still wanted to point out eliminating stigma and discrimination against HIV is still a major goal of our hope in terms of the fight over HIV. However, I cannot forget to give these slides on zero HIV infection, zero discrimination, and zero AIDS-related death. This is of our aspirations. What are the tools we have to be able to achieve our aspirations? Well, in prevention, we have had quite a good run. We have quite a number of tools that have shown quite good potential for prevention. And these are fairly very well, efficacy have been demonstrated. But, ladies and gentlemen, I really can't actually underestimate the impact of modeling to actually giving us a dream. These modelers, the first papers on modeling, on trying to look at what we can do if we scaled up all this prevention, really was, in fact, I remember reading them and I'm like, this is way out. But they galvanized the impetus or the momentum to really do something about it. Well, they show that we can actually achieve some remarkable reduction in incidence if we actually can scale up this intervention, which we are trying to do now. However, as many of you may have seen this Economist, we are now talking about the ends of HIV or AIDS. And we think that we can be able to achieve these targets if we all move in the right direction. Let's talk about care. Many of you, I borrowed this slide from Julio. I'm very inspired by this slide. I remember attending this meeting. I had a brother at that time who had HIV, and I remember coming out with a lot of hope, actually. For the first time, there was a lot of evidence about triple therapy and its efficacy, the ability to monitor this with viral loads. And I remember going back, thinking there's a lot of hope, but the costs were very expensive. They were really very expensive. It was really out of our dreams. However, the drum started to beat. And in Durban, we were demanding treatment for all. And I remember being among the skepticals, to be honest, because I really didn't think we would be able to have the resources, nor be able to have people in Africa being able to actually being very compliant. However, PEPFAR was a real game changer. To be honest, it was. I have people in areas I work in Uganda, in the rural areas, who are still alive. I'm actually as stunned as they are that they actually arrived. But it put a lot of money on the table, and it has been able to really make a huge impact on the dynamics of HIV transmission right into the rural populations of Africa. Resources, to be sure, have really been galvanized, and this shows how much we have over the years. But, as I'll argue later, we still need to sustain this over a long time. The reality, what's the reality? The HIV epidemic is not simple. Scaling up has a lot of issues, funding, politicians. I'll explain a little bit quickly about this. When I attend meetings in Kampala now, and we are talking about epidemics in Kampala, I'm like, where am I? We talk about men having sex with men. There's been a lot of data generated by Crane Survey. We're about to start our MAP estimations of men, but this was put on hold. But this wasn't something I was really talking about 20 years ago in Uganda. IV drug users, yeah, the big deal now in Kampala. But the fisher folks are still a huge problem, as they have always been, and so are the commercial sex workers. These groups, it's really amazing, the poor or no health services available. Yet they are huge drivers of the epidemic. You go to lectures teeming with a lot of young, active, dynamic men, HIV prevalence of about 40%, no services at all, no services. And this is the reality. And yet, this is where, if you talk of the right place, this is where one should be. The other issue in the epidemic is, I'd like to share you briefly about this data from Rakai Health Science Program by Kate Bromoski. We find that a lot of transmissions are within household, about 40, but another 40 is outside transmissions. Of those 40, 60% are from way out of the communities of where these people live. And when you look at a slide like Uganda, they are as far out as this is Rakai, but you find when you look at their networks, they're as far out as every corner of Uganda. The spatial distribution, the dynamics has evolved as good communication, roads, cell phone communication has also changed. The dynamics is also changing. People can move quickly and easily from one place to another. We have to take into account that. Coverages, we talk a lot about coverage. We do know if you do have good coverage, you're going to make an impact on this epidemic. We do know, and I'm going to show you some data to that. However, we are having a slow start. We have been having a slow start, but picking up. But there are some realities that we'll discuss about. This is showing circumcision per year over the countries. This is shown up, as Deborah has also shown in most of her slides. We still have a long way to go, however, to achieve some of the required coverages that we really need, say, for circumcision. These slides are very familiar with you. 60% of people in Africa are getting HIV. Those, we are talking about 30 people living with HIV receiving antiretroviral therapy, which is remarkably similar to what we see also in Rakai Health Science Program in a rural population, still 30%. So, however, despite that coverage, this is a slide showing incidence and prevalence. The blue line is incidence, and the yellow line is prevalence. Since we started treatment programs in 2004, you can see that there's a huge change in incidence. Incidence is coming down. This is with about a 60% coverage of the population, and about a 50% for treatment and 50% for circumcision. We would like to think over time whether this curve is different from this curve. There is impact. There is surely impact on this combination prevention moving forward. However, when you're dealing with the denominator, the population, as opposed to health centers, the reality is more real. Despite people actually being told they are eligible for treatment, treatment is free, not everybody comes. There are various reasons. Stigma is one of those, but as we discuss later, health system is another. But what you see is the early adopter coming in to pick up those numbers, but we need to actually be able to create demand for those people who are eligible for treatment, but they are still healthy and they don't want to come. And this is where new innovation for creating demand for services, circumcision, treatment, testing, and counseling is going to be very critical. We need more innovative ways. To get to 90, you have to take this outside the realm of just purely medical. We need to learn something from cellular networks, which have created so much demand and people use cell phones everywhere. We have to think something else. How can we get healthy people, healthy-looking people come for services to be able to get to that 90? It's going to be a very important challenge moving forward. Health systems is going to be a huge problem. Health systems, health workers, we have a lot of investment in ARVs, circumcision, but when you look at the budget for actually scaling up health workers and sustaining and motivating health workers, it's a very small percentage, which is true in many cases, but it's amazing how we underestimate the funding that is required to bring up the health workers and also to bring up the health, the laboratories and the logistics. That is something that will require attention if you're going to get to 90. Well, the other challenge, I hope, Deborah, this is a true reflection. This is PEPFAR funding. We have leveled off on PEPFAR funding, though Deborah Bax did make a good point of how you can achieve higher targets even despite leveling off this by increasing efficiency. But this is a worrying trend moving forward. This, I knew that Alan was one of the discussants, so I wanted to excite him with these graphs. These are some of the graphs from Midover in his report on Institute of Medicine. But the graph that I really wanted you, this shows number of people, number of infections projected forward, expenditures, and affordability. Expenditure needs to go up, or will need to be going up, especially when you factor in second-line treatment or more expensive drugs moving over time. The good news is that this expenditure, at least in Africa, will increasingly over time be a smaller percentage of public health expenditure, purely because GDP for Africa has sustainably been very high. And if we really sustain that, the expenditure might go down, which might be a hope. Other challenges. The other challenges are the politicians, the politics, laws that are coming up increasingly. I have a picture here of my president signing a law for the anti-gay bill. This is increasingly a big challenge. Other speakers have talked about it. But there are realities to and consequences to these laws. Possible solutions. The GDP of Africa is going up. I've been very proud of showing this Economist of December 2030. A little bit disappointed by the Ebola and how we have reacted to it. But the GDP is fairly high, been sustained for a while. With good leadership, shared responsibility, there are options. We'll hear later on in this meeting what are the other funding options. But there are options to be able to have be able to share the responsibility of funding this epidemic moving forward. The road ahead, though. We need to increase and sustain the funding. We are in a long haul. Anybody who has read a book on the fever trail on malaria, we dropped it in the 60s. Funding went down. Malaria came back. We don't want to go that road. I'm always energized by what can HIV epidemic and the response to the epidemic teach other diseases. And there have so far been some very good reasons, good teaching lessons, political support, and the ability to leverage to bring the dollars onto the table. Improvement of health systems is going to be a huge challenge moving forward. In order to achieve this, if you create demand to get to that 90-90, you have to have a health system that can be able to meet that challenge. And always, as always, leadership will be very important. Thank you very much.
Thank you very much. David? No, you stay here. Stay here.
I thought I was off.
You will probably be challenged.
All right.
So now ask Professor Wafa Al-Sadr to make a comment.
Yes. Well, thank you very much for the opportunity to have a few remarks, and I know we're trying to catch up, so I'll be brief and succinct. First of all, thank you, David, for incredibly comprehensive overview of some of the challenges that are faced in dealing with our aspirations versus the realities that we all face. I think it's interesting that a few months ago, some colleagues of mine and myself, we put a thought piece in the issue of Science that came out in conjunction with the Melbourne International AIDS Conference that was entitled End of AIDS, Hype versus Hope. And in that piece, we tried to think about what are the lessons learned from history of pronouncements like the end of AIDS. Have they helped or have they hurt public health endeavors? It was very interesting to go back historically and look at some of the very successful campaigns, for example, the smallpox eradication campaign, and others, the success thus far in polio elimination, hopefully eradication with few exceptions in some countries. And then contrast that with some other campaigns, for example, malaria that was just mentioned, as well as, of course, in the United States, the war on cancer. So the lessons learned is that often at the time of initiation of even the most successful campaign like the smallpox eradication, at the time when it was announced, actually there were many naysayers, and that's been forgotten because we celebrate the success of this campaign, but we often forget that at the time that it was initiated, many thought that it was impossible, unwise, and doomed to failure, and of course we know the success that emanated from that campaign. At the same time, there are lessons learned from other campaigns that have not been as successful for a variety of different reasons. Sometimes it's been because of the lack of bringing together the necessary stakeholders, the people to the table. Sometimes it's been a lack of anticipation of the changes in the disease and the pattern of disease. And sometimes it's been around issues of what to prioritize. So I think there are lots of lessons learned from other campaigns that can inform us as we seek to end AIDS in our lifetime. And those are the kinds of things that I've heard earlier today from David as well as from other speakers earlier this morning that are very encouraging that we can and hopefully we will end what I call epidemic AIDS in our lifetime. So how can we accomplish this? I think we can accomplish trying to make the aspirations into reality is going to be very important. But how do we do that? I think critically, I think we need to take those aspirations and break them into small pieces so that there's often almost, I call it like a manual of operations. It's almost like telling you step by step, how are we going to reach our aspirations? What are the steps along the path that will enable us to see if we're making progress, and if we're not making progress, why are we not making progress, and adjust our response accordingly. So the ability to develop a path towards achievement of the aspirations with very clear targets and milestones along the way is going to be very important. And having the courage and the flexibility and the innovation and the ability to reflect and change course is going to be very critical in order for us to reach our aspirations. In addition, of course, what's very important is going to be continuing to utilize some of the lessons we've learned from the response thus far. The importance of focusing, the importance of prioritizing, the importance of innovation, the importance of flexibility, the importance of partnerships, the importance of engagement of the community, and the importance of focusing on building an infrastructure that will be durable. Those are things we've done thus far, and I think are really the attributes that enabled us to achieve the success we have achieved so far. So I believe that as we move forward and have ambitious aspirations, whether it be the end of epidemic AIDS or 90-90-90, it is really critical that all of us as a community that's very committed to turning around this epidemic, that we do the hard work of developing the milestones and the targets and working together to see along the path, are we achieving our targets, are we achieving our milestones, and then are we adjusting our responses so we can move forward in achieving ultimately our global aspirations. I'll stop here and hand it over to the next speaker. Thank you very much.
Dr. Nosek, please.
Well, thank you, and thanks for the invitation to serve on the panel. Thanks to David for a great presentation, nice overview. I tended to hone in on data collection, in particular, when David spoke, and I was really glad to see the care cascade presented for Rakai, and it makes me think about our new mandate set up by UNAIDS, our 90-90-90 mandate. And what I like about it is that it articulates with a great deal more specificity how we need to focus our efforts to fight the HIV/AIDS pandemic. And really the first step in doing this is measurement, measuring how many diagnosed cases you have, how many are linked to care, how many are receiving treatment, and measuring at whatever scale is feasible for a given country. But I would really urge you to consider the value of the investment that you make in collecting data on your HIV/AIDS epidemic. You know, and I'm glad to hear it's a theme that almost every speaker has touched on this morning. I'm really glad to hear it. And I think that sort of thinking has gotten us all on the same page. You know, I just had a conversation with a fellow working in India, Sunil Salaman, who's going to be presenting later this afternoon. We talked about his efforts to scale up HIV care in India, and he knew precisely where they were losing individuals to care in HIV, and they were focusing their efforts on that basis. Same goes for our work with Zunyu Wu and the Chinese Center for Disease Control. They know they have a big problem. After they diagnose individuals, the processes they've set up in their hospitals make it so that they're losing a lot of people after diagnosis, so they have trouble linking people to HIV care afterwards. So, you know, just to get that information is a big step. You know, so informed by tools like the HIV Care Cascade, we can be more strategic about how we're allocating funds, not only at specific stages of the care cascade, but also taking into account differences in engagement across regions and demographic groups. And I heard Dr. Birx mention it this morning. There's a beautiful paper from Tim Hallett's group on how they've on their approach to doing this in Kenya. So the bottom line is better quality information. It's going to lead to better resource allocation decisions. Data collection is the first step, and I would strongly say, you know, the second step is use of modeling economic evaluation to help guide those decisions on the margin, which are going to be very difficult to decide on. And I have to say, as a health economist, I'm a little biased in that regard, but I do think there's a valuable role to play there, because we're dealing with a limited investment. We need to make the most of what we have. Thank you.
Thank you, Dr. Nozick. Dr. Fabio Mesquita.
So thanks, Celso, and first of all, thank you for the organizers of the meeting for this invitation, for this opportunity to comment. A very comprehensive presentation from David. It was very interesting. In his line of history, I just would add that by the year 1996, we started a big fight for pricing of antiretroviral therapy, and basically with the productions of generic drugs that pushed a lot for the downsize of the prices of ARV. That was a very key moment in history to improve the access to antiretroviral therapy. Of course, he showed the price by the time that was about $24,000 to treat one patient, and we got to a point that now we can treat one patient with first line for around $100, and this is a big difference. And we are facing that on hepatitis right now, and this is a very key element of the history of access on ARV, including the changes in the pharmaceutical industry that now have a access policy that is completely different from their commercial policy. And I think this is another victory of the history of the HIV movement. I saw as well the Durban conference as a turning point, for first of all to look after sub-Saharan Africa that was left out until the year 2000, and the impact of all the interventions after the Durban conference, including the creation of Global Fund, the creation of PEPFAR, and all these interventions. The good thing about the UNAIDS report that Dr. Burke also mentioned here, the GAP report, was basically because it's very clear now that we were very successful to impact the epidemic in generalized epidemics, but in general, all over the world, somehow a failure to impact the epidemic in key affected populations. And this is the data from many countries in the world where the epidemic is concentrated, and including sub-Saharan Africa, and that was mentioned by David and Dr. Burke, when she presented that even in sub-Saharan Africa, key affected population is still left out. So I think the big challenges we have today is how to focus on key affected populations, how to don't leave or leave out men who have sex with men, sex workers, but somehow there is at least a commitment to those two populations in most of the intellectual debates. But particularly there is left out very clear for trans people that we normally treat as men who have sex with men, and they have their particularities that are very important to deal with. Like if we consider in our case in Brazil, we are finding the prevalence rates among men who have sex with men around 10%, which is it's almost 20 times the general population in Brazil. But in trans people, we are finding 16%. It's even higher. And people who use drugs, who were left out in most of the places in the world. Of course, it's very complicated for governments to focus on these populations and answer the questions why you are investing public money in people who use drugs or in trans people or these kind of questions that still 30 years after we still face. And the question about access to treatment, we have some answers and we need to work on that answers. And like we are implementing in Brazil since December of last year, test and treat. Basically, we're treating everybody who is HIV positive. And the biggest resistance are somehow from a sector of the non-governmental organizations that have a very old-fashioned understanding of the epidemic and the effects of the drugs. And therefore, people who used the first drugs 30 years ago, 25 years ago, and say that the drugs are very problematic and they will cause a lot of side effects and a lot of resistance, a lot of problems. And they speak on behalf of everybody, including new people with new drugs. We have resistance from doctors that still have the same feeling that the ARVs are worse than the virus, and therefore somehow some of them resist to prescribe. And we as health sector somehow resist to use peer approach for testing, which is a very important strategy since some of these most affected population will never come to the health sector because they don't trust in the health sector. They are discriminated in the health sector. And they need an intervention that we go to them and not they will come to us. And we learned in 30 years of the epidemic that peer approach was very effective for prevention, but we don't use that for testing or for referring people to treatment. We don't use the peer approach as a very key strategy. And we also resist, as health sector, to use new technologies. Point-of-care diagnosis or these simplified technologies that we see all the evidence that works as well as very complex laboratories, but we tend to send all the samples for very complex laboratories, and therefore, in the developing world, it's very heavy or very difficult to organize very complex laboratories or very cost laboratories. And I think this is another challenge for us. In terms of long-term sustainability, One of the things that we are seeing now, after almost 30 years, is the optimization of the donors. Finally, some of the donors are sitting together, are talking together, are thinking about a collective strategy and optimizing the way they use their money. The focusing was very important. Cost-effective interventions are crucial, like everybody loves to do education in school because there's no polemic, it's politically very nice, but it's not effective, or it will take 30 years to have some effective. So this kind of cost-effective interventions are very crucial. And everything should be human rights-based, respecting the rights of everybody. And so as I would agree with Michelle that for all these changes, leadership is crucial. And it's crucial in the sense that we should be open enough to work as a leader together with all other leaders, and not to be the only person or the only organization that can save the world. We need to join forces to fight HIV. Thank you.
Thank you, Fabio. We pass on to our last speaker.
Right. Thank you very much. 4 slides, 4 minutes. And what I've tried to do is take what David said and frame it into 4 sets of constraints that I think we face in dealing with this epidemic. The first set is the individuals. How do we get people on treatment? How do we keep people on treatment? And I think one of our failures in this AIDS community working on this disease is to perhaps underestimate the psychology of people needing to go on and keep on treatment. And anyone in this audience who's on hypertensive medication might want to make a comment on that reality that we face, or statins or anything like that. So psychology, I think, is hugely important. I think stigma is important, and I think the environment in which people operate is also incredibly important. The second set of constraints that we face I describe as systematic, or systemic, depending on how you pronounce it. And here we are talking primarily about the healthcare system, recognizing that it operates in an environment of national and international governance. Now, I have to say, I think unless we're extraordinarily imaginative and start putting in place the ability for treatment to be rolled out at lower levels, we are not going to succeed in doing what we aspire to do in terms of dealing with this epidemic. The question of stockouts and maintaining drug supplies is not spoken about, and it bloody well ought to be, because we've seen that in South Africa at Int'l, where effectively 6,000 patients went without therapy for a number of days. And what are the implications of that? And I think that again speaks to the earlier slide. If you can't put people on treatment and assure them of treatment, you've got a problem going forward. The financial constraints are huge, and David mentioned Meadover's work. There were some documents that I saw recently which suggest that if we roll out treatment in South Africa, the entire health budget will be being used for it. And that's clearly not going to happen, so we need to think clever about this, and we need to address this as an issue. Also linked to this is the question of donor dependence. How do you feel if 40% of your population are dependent on somebody else's goodwill? How do you feel as a nation? How do you feel as individuals in that nation? How does the donor feel? I well remember an excellent piece written by Princeton Lyman about the rollout of PEPFAR, which was entitled, "No Good Deed Goes Unpunished." And there is this problem that we face in terms of donor dependence. And then we need to think about the long-term commitments and the sustainability of what we're looking at. If we took a young man in my town, eThekwini, Durban, who is infected today, he might need treatment from 2020, and he will probably need it until 2054. That's 34 years of treatment. If you take a young woman of 20, she's probably going to be pregnant, and she's going to need 40 years of treatment. I don't think many of us will be around in 40 years, some of the younger people in the audience, but I think some of us won't be. But I do think we need to look at this long-term issue that we are leaving to the healthcare services in our society. And then finally, I think the last set of constraints, as David so eloquently put the constraints, and as I've tried to frame them, are political. And we come back to political economy, and the economists began there. There are some issues of equity which we don't talk about. If we have somebody on treatment in Malawi, it's probably costing $120 per person per year. The health expenditure in Malawi, $34, less in other countries. There are real issues of equity that we need to address. I'm not saying we can't do them, but I think we have to be realistic about it. I think we need to also understand that there's a lack of voice, and finally, that these retrogressive attitudes to IDUs and MSMs are just unacceptable. And that, for me, is one of the real issues that I would like to hear discussed at this conference. It's not enough to put up a map which shows where MSMs are being prosecuted. We actually need to do something about it. So, and the last thing I want to say is, I put up 4 sets of constraints. You all know this. I've not said anything new here. You all know it. But you all work in one of those areas. What you need to do is be aware and see that people who work in the other areas are your allies, and be their allies as we move forward in dealing with this epidemic. And finally, why did I use slides? So they're on the record, and anyone can take these and use them, and please do.
I would like to thank all panelists. For the sake of our time schedule, the audience, I will have to refrain from calling the audience to make comments and questions, and I myself will also refrain to do so in solidarity to you. Thank you very much.